Please continue holding until your host arrives. 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 Please continue holding until your host arrives.
There was a good
You
result.
will now be placed into the conference.
Afterwards. This was about a month ago, and she'll come back for a repeat echocardiogram and see if that improves in any way after the PVC ablation. So we'll move on to another case. 40-year-old, healthy male, presents with dyspnea. I'll just say right now his echocardiogram was normal, and take my word for this, that this is ventricular tachycardia. How do you manage this? So he comes into the ER, this spontaneously converts. So I'm not talking about acute management, but more of chronic management. Do we think about some type of medication, verapamil, metoprolol, and antiarrhythmic? Does he warrant ischemic evaluation, more imaging, or does he need a secondary prevention device at this time? So this is a segue into a section I just want to go into briefly, which is idiopathic VT. So this is likely left posterior, left fascicular VT. It kind of has that very classic right bundle, superior axis pattern, but I think one of the most telltale signs is that you have this very narrowish QRS complex. Idiopathic VT is kind of a catch-all term for sustained VT in the otherwise structurally normal heart. So I kind of want to just run through this really quickly, but the reason I bring it up, and it encompasses quite a few different types of VT, for example, outflow tract VT, pap muscle VT, fascicular VT, the risk of sudden cardiac death is low. So it's generally tolerated well, it has a good prognosis, and these are generally people who don't need an ICD. Generally, not always, but generally don't need an ICD. These are guidelines, generally an excellent prognosis, and this is 2012 device guidelines, ICD therapy, not indicated when it's amenable to ablation. Fascicular VT, specifically, it can be verapamil sensitive. It's a re-entry circuit rather than a focal mechanism usually, which involves the distal Purkinje fibers on the septal side of the left ventricle. You often see it in young healthy males. It can be exercise induced. Verapamil works very well. IV verapamil works well. PO verapamil can work as well. You can have breakthroughs. Beta blockers generally, by the textbooks, have lower efficacy. And you can use antiarrhythmics as well. Catheter ablation is a good tool. The success rates are reasonable. And like I said, it involves a re-entry circuit in the distal portion of the conduction system. And the goal is to try to tempo ablation in the distal section here so you're not causing any problems with their inherent conduction system. So again, I just wanted to go over this for sake of completion, but what I want to spend most of my time on is structural heart disease. So I'll break this up into a couple of sections, but as opposed to the prior discussion, this, as you all know, carries an elevated risk for sudden cardiac death, and ICDs are the standard of care, and I'm not going to argue against that. And what I want to focus on is the role of catheter ablation and data behind catheter ablation. So we'll break it up into two sections, which I'll explain why. VT in the post-myocardial infarction patient, and then all of the other types of non-ischemic cardiomyopathies that we routinely see. So a little bit of pathology and pathophysiology. This is a growth sample, and you see some relatively normal tissue on this side. You see some dense scar, and what causes ventricular tachycardia is an area in between the dense scar and the healthy tissue that we call border zone tissue. And so you have this bed of still surviving, not dead tissue with decreased cell-cell coupling, and it has slow electrical conduction in this area, which predisposes to reentry circuits. I think this is kind of the ideal VT circuit that we picture in our head. You have lots of healthy tissue, you have this gray scar, and you have this nice, very nice reentry circuit. You have this one entrance site into the scar. You have this long, what we call isthmus, where the slow conduction propagates, and you have one nice exit site back into healthy tissue. I think often it ends up looking like this, where you have lots of corridors, lots of entrance and exit sites, and at least when I'm in the lab, I feel like we're playing whack-a-mole, and you hit one mole and there's other exit sites where the VT can exit into. I don't have any cats. That was from Google. You can, depending on the exit site, you can have different morphologies of the VT. So depending on if it leads here, 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 your 12-lead configuration can look different. So there's many people with different types of VT which can come from the same relative areas of scar. Now, before we talk about some of the management, I just wanted to talk about the VT and other types of cardiomyopathies. As we know, there's lots of other reasons to have cardiomyopathies besides scar from a myocardial infarction. And the reasons I want to make a differentiation is because of where that circuit or the exit site for VT is. Usually in post-myocardial infarction VT, it's usually subendocardial, meaning we can reach it with the catheter. You don't always see that with some of these other processes where the exit site or the circuit can be mid-myocardial or epicardial. This is another gross sample. You have the epicardial surface on the bottom, and here's the endocardial surface. Here's a lesion made with an endocardial catheter, and you see that it doesn't even break the mid-myocardial area, much less if there was scar or an exit site on the epicardial surface. So dilated cardiomyopathies, this is a stack of short axis samples. The epicardial edge is traced out here, and you see there's late enhancement along the epicardial site, but the endocardial wall is relatively preserved. This is someone who came in with VT. They initially attempted an endocardial ablation. They were unsuccessful. They went epicardial and they ablated, and they were successful in resolving the ventricular tachycardia. ARVC begins subepicardial usually and works its way inward. Here is mid-myocardial delayed enhancement. HCM, you have really thick hearts. This is scar, and you could think about the feasibility of putting a catheter in here and trying to reach a circuit that's over here. So it's much more difficult, and it affects the success rates, and I think that's why there's a big distinction between these. So treatment. Again, I'm going to focus on ablation, but quickly talking about ICD therapy and medications. Not much to say about ICD therapy. It's the standard of care. I can't think of really any situations where you should think about amnio or a catheter ablation rather than an ICD in someone with VT and a structurally abnormal heart. That being said, ICDs aren't perfect therapy. They're there as a safety net, and as we all know, there are serious risks and complications, morbidity and mortality from people who suffer ICD therapies. And the goal is to minimize ICD therapies. People can have medical issues, heart failure, etc., as well as many psychological problems, depression, anxiety, PTSD from ICD shock. Medications, in general, antiarrhythmics don't improve survival, but the role is for arrhythmia and symptom control. Beta blockers are great. They have a number of different mechanisms. They can augment antiarrhythmics. Calcium channel blockers, not really any role outside of the structurally normal heart. Our general antiarrhythmics for VT in the structurally abnormal heart are amiodarone and sotalol. Amiodarone is a good medication. Sotalol, not as good, but it is good, and it has, for many people, less toxicities. This is a forest plot from a number of studies which showed benefit for amiodarone, but not so much for sotalol. And as we know, there's mortality and there's toxicity. There's some evidence that amiodarone may increase mortality, and in some studies that the toxicities from amiodarone are as high as 30% of the population in that study. There's a few other medications we don't generally use as monotherapy, but augmenters in addition to amiodarone or sotalol. Ranolazine, which is a sodium blocker, mexilotine, quinidine. The efficacy is not great, but they can help in the right patient. So catheter ablation. Just a very brief overview. I don't want to go over too much of what we do in the lab, but I wanted to go over a couple of quick points because I think it helps to lay out some of this discussion and some of the data. So again, what we're really concerned about is this border zone tissue in between areas of dense scar, which serve as a nidus for a reentry circuit. These are some of the catheters we use in our lab, which have electrodes on the distal tips. And when we put them into a heart chamber, we create a three-dimensional shell. And as we're creating a three-dimensional shell, we're able to pick up points of local electrograms from all of those distal electrodes. And depending on the voltage of these electrograms, we can differentiate healthy tissue versus scar. And we have certain cutoffs we use in general that differentiate normal tissue, scar, border zone tissue. And with that three-dimensional shell, we can in a perfect textbook scenario, pick out what scar, that red color there, versus healthy purple tissue and the border zone tissue in between, so we can kind of define where the scar is, where the isthmus is. So what do we do? Again, without going into too much detail, we kind of figure out where those areas of scar are, where the border zone issues, where the border tissue is, and we can either ablate the clinical VT, where we use certain maneuvers to try to figure out where that central isthmus is and burn there, or do something called scar or substrate modification, where we not only take care of those isthmuses, but take care of all of that electrical gray borderline tissue and turn them into dense scars so that they're no longer a nidus for a reentry circuit. So the questions are, when should we consider catheter ablation? And is there a role for catheter ablation in lieu of or instead of antiarrhythmics? And I wanted to briefly go over 4 RCTs, which I hope help answer these questions to a certain amount. So first one, SMASH VT, Boston, with Josephson, and when Vivek Reddy was there, multi-center trial, 128 patients. I'll point out that all of these trials have a low number of patients. It's fairly difficult to enroll for these VT studies. So they looked at patients with a history of prior MI with VT-VF, and they randomized them to catheter ablation or ICD alone or ICD plus catheter ablation. They didn't map the clinical VT. They just did what we call substrate or scar modification. And the primary endpoint was survival-free from any appropriate ICD therapy. And importantly, they excluded all patients on antiarrhythmics before and during follow-up. What did they see? They saw a reduction in the catheter ablation group. There was no significant change in mortality. There was a similar study done, a European multi-center trial, again, 110 patients. Differences here, they looked at low EF and they looked at only stable VT, and they randomized them similarly. So ICD alone or catheter ablation followed by ICD. In addition to doing substrate modification, they try to ablate the clinical VT. Primary endpoint, time to first recurrence of VT or VF. Importantly here, about a third of patients were on amiodarone in each group. So they found a similar result, improvement in freedom from VT in the catheter ablation group. And the same group, I will say there was a sub-group analysis here where the benefit seemed to come from people with a higher EF, an EF greater than 30%. They had less events in this group, if that means anything, but the benefit here was really from the higher EF group. So the same group then did another study, lower EF, but now hemodynamically unstable VT, randomized them in a similar fashion. Again, similar primary endpoint, time to first VT-VF recurrence, and again, about a third of them were on antiarrhythmics. This was the first study which showed no difference between these two groups. However, in the catheter ablation group, they had significantly less occurrences of VT-VF and ICD therapies over the follow-up of about 2 years. So no change in time to first recurrence, but after that, they had significantly less events. So all of these showed that maybe you have some symptom improvement and decreased therapies with catheter ablation, but none of them looked at them in comparison to antiarrhythmics. This came out 2 years ago in the New England Journal. This was primarily a Canadian study that had slightly higher patients, 260, who had an ischemic cardiomyopathy, who had an ICD, who were on antiarrhythmics, who came in with VT. They randomized them to either catheter ablation with continuation of their current antiarrhythmic regimen, or they escalated their antiarrhythmics according to this protocol. So if they were on a non-amiodarone antiarrhythmic, typically sotalol, they started amiodarone. If they were already on amiodarone, they either increased it if it was less than 300 milligrams daily, or they added mixilotine. Their primary endpoint was a composite of death, VT storm, or appropriate ICD shocks. Their primary endpoint, again, improved in the catheter ablation group. This was really driven by rates of VT storm and appropriate ICD shocks rather than death. And if you looked at subgroup analysis here, this was really driven by people who came in with VT on amiodarone who underwent catheter ablation. So another way to say that, someone comes in with VT, they're on sotalol, didn't make much of a difference if you randomize them to sotalol or randomize them to amiodarone versus catheter ablation. However, someone comes in already on amiodarone, they did better with catheter ablation rather than increasing the amio or adding mexilatine. Again, the side effects from antiarrhythmics can't be understated. They had 3 deaths out of 127, which were felt directly attributable to amiodarone use, and there were a number of toxicities. We'll go over the complications of catheter ablation in just a little while. None of these show a mortality benefit. There's no prospective data that show any kind of mortality benefit. Probably the largest retrospective is Roger Tung. They looked at 2,000 patients from very high volume experienced centers. They had a fairly high 1-year freedom from VT after ablation of 70%, and surprisingly it was fairly similar between ischemic and non-ischemic VT. And they saw a combined transplant mortality rate of about 15% in 1 year, with a decreased rate in those who underwent ablation and didn't have VT recurrence. Other people's data is lower for outcomes. This is Penn's group, who had a 1-year recurrence ranging from about 23 to 49%. This is a graph of number of VT events pre and post ablation. Each horizontal line is one of 139 patients. You see there's many patients who had a high burden, underwent ablation, and had no events afterwards. There are many people who had a high burden and had a small burden afterwards, and there are some people who still had a high degree of refractory VT. There's some data to suggest that you may have improved success when you do substrate or scar modification in addition to ablating the clinical VT. There's better outcomes in general with post-myocardial infarction VT, like I talked about. Again, the reason for that is you generally have more epicardial scar or exit sites or substrate in a non-ischemic cardiomyopathy compared to ischemic cardiomyopathy. Here's one patient where they did voltage mapping endocardially. It's fairly normal, healthy, purple tissue throughout, a little bit of scar, and when they did epicardial mapping, you see a large amount of scar on the epicardial surface. There's some data to show now that you have better outcomes in non-ischemic cardiomyopathy once you start looking at epicardial ablation, and there's more centers that are using this more frequently. This is a patient with ARVC where they initially started ablating endocardially, still had VT, and had success with epicardial ablation. Complications are not trivial. I think out of all the procedures we do, it has the highest complication rate, where most of our procedures probably have acute complication rates of around 1% or so. These are much higher, and obviously it's a much different patient population. It's usually not an elective procedure. They're usually sick, a low EF, high NYHA status, etc. I think the thing that we usually see is some degree of hemodynamic decompensation. They often have to be in VT during the procedure. They're already fairly sick. They're often going to the ICU afterwards. Sometimes they need advanced mechanical support. This is the largest retrospective study. This is about 2,000 patients at about 12 centers, which showed a 30-day mortality after VT of about 5%. They looked at a number of risk factors in these patients, and they thought these were the highest risk. Patients with COPD, advanced age, ischemic cardiomyopathy, NYHA 3 or 4, low EF, VT storm, and diabetes. They gave them risk scores, and they found a risk of about 15 or so, portended the highest risk. So, summary, catheter ablation, I think, does provide symptomatic benefit, and it can minimize ICD therapies. There's no prospective data regarding antiarrhythmic therapy versus catheter ablation. It's first-line treatment. But I think, and I argue that it should always be considered, and it may be first-line treatment in the select patient, obviously in addition to ICDs, and it may provide an amiodarone-free treatment modality, whether that's no antiarrhythmics or whether that's the use of sotalol. There's possibly higher efficacy in the post-myocardial infarction VT, but with increased use of epicardial techniques, that may be changing. Catheter ablation does carry non-trivial risk. as we talked about, and for that reason, patients should be chosen very carefully. I didn't go into this, and it's a little outside the scope of it, but just some bullet points that technology has continued to improve both the safety and efficacy, both with our three-dimensional mapping software and hardware, as well as our catheter technology, and as well as the use of planning with cardiac imaging and defining scar before a procedure. Another case, so a 77-year-old gentleman who had distant inferior MI presented with palpitations. He comes in with a slow, hemodynamically stable ventricular tachycardia. Looks like it's left-sided coming from the inferior wall, possibly this area here. He converts after receiving an IV amiodarone bolus. He has cardiac imaging, which shows a slightly depressed EF of 40% with inferior transmural scar, and he has a left heart catheterization without significant disease. So the question is here, what do we do? Should we put in an ICD? His EF, it's not less than 30-35%. He didn't have a sudden cardiac death. This was hemodynamically stable. Does he need an ICD? If he does, should you use an antiarrhythmic or catheter ablation? Should you try to see if you can get away with just an antiarrhythmic or catheter ablation alone? Or should you say this was just one event and should we wait for another event and maybe do something if it comes back? So in him, we put in an ICD. I think he has the substrate such that he can have VT in the future, and the next time he may not be as lucky and have this slow circuit. He has a depressed EF, and he has scar from prior myocardial infarction. So I don't think this is idiopathic VT. I think this is structurally abnormal VT. So he had an ICD, and I think you can argue that you can just do that and nothing more. You can have a discussion with him and see if he wants an antiarrhythmic. I think those are both very reasonable options. While he was in the hospital, he kept having episodes of the same monomorphic VT. It was always stable, maybe some palpitations, but hemodynamically stable. He was very young and active for being 77. He traveled a lot, played a lot of golf, wanted to minimize medications as much as possible, and so very reasonably he went for catheter ablation. There was dense inferior scar, where we found a VT circuit which was ablated, and he had additional scar modification. So we decided not to use any antiarrhythmics in him. It's been about 3 months, and he's been doing well since that time. So I wanted to spend just a few minutes talking about some of the emerging technologies for treatment of ventricular tachycardia. They all kind of have the similar endpoint. The goal of all of these is to attempt to deliver deeper lesions that reach some of those mid-myocardial or epicardial circuits. Just as caveat, all of this has sparse data. The efficacy and safety are a little unclear, and many of these are enrolling. So transcoronary ethanol ablation used for deep circuits, mainly septal circuits. Unfortunately, you see a high degree of complete heart block. This is probably the largest case study from Boston, where many of them were septal perforator lesions. You see here a patient who had a septal circuit. They kind of carpet bombed the entire septum, were unsuccessful from both the right and left sides. This ablation catheter is where the exit site, presumably, of the VT is, and so they inflated a balloon and infused alcohol, and he had a successful result from that. Bipolar radiofrequency ablation. So here is the septum, and there is an ablation catheter on both sides of the septum. And by delivering energy between the two catheters, you're hoping to create a deeper lesion. This is an example of delivering a lesion sequentially from both sides of the septum, and you see you're still not getting a deep lesion. Whereas by delivering between the two catheters, you get this nice transmural lesion. This is currently enrolling, but there's an increased risk of perforation, possibly LV dysfunction with this much damage. This is similar in a way. This is a needle ablation catheter, so this is a retractable needle. So you put the catheter in, and when you feel like you're at a good spot, you extend this needle into the myocardium and deliver energy. It can also you can also infuse saline in contrast to make sure you're not in a bad area. This is also enrolling. I thought I'd spend a few minutes on these slides since this made some headlines a month or two ago. This was a New England Journal study where they use stereotactic radioablation. So this is used and managed in the solid tumors, and the nice thing about this is it delivers precise radiation with minimal damage to adjacent tissue. And so there was a protocol created which was completely non-invasive, where they delivered 25 to 35 gray, hoping to mimic the effects of catheter RF ablation, and with the result of creating late myocardial fibrosis. And so this was at WashU in St. Louis. They took 5 very, very high-risk patients with recurrent refractory VT who had no other medical options. And what they did is they underwent imaging, MRI or SPECT, to define areas of scar. They wore a 256 electrode vest, and using their own ICD, they were induced into ventricular tachycardia. The VT was mapped, and between these two modalities, they were able to create a reentry circuit and define where the exit site was, and they targeted that exit site. So they defined an area of radiation and expanded it slightly to account for patient motion, et cetera. And they, I don't know what goes on here, but they went through there. And this was the impressive thing. I'm not talking about that. So during 3 months prior to treatment, they had a combined history of 6,600 VT episodes. There was a blanking period for 6 weeks while the fibrotic changes were taking effect. And then after the blanking period, they had a combined 4 episodes of VT total over the follow-up period of 46 months. There was 5 patients. 1 patient died a month after treatment. It was someone with AFib and multiple CHA2DS2-VASc risk factors who couldn't take anticoagulation and died of a stroke. Whether they died because of that or because of something secondary to the radiation, it's unclear. The rest of the patients did quite well. You can see they were off of antiarrhythmics for 3 patients stayed off antiarrhythmics, and 1 patient went back on antiarrhythmics at 10 months. As far as they could see, over the follow-up period, there were no significant side effects. There was no drop in EF. Some people had some lung changes which disappeared after a year. Obviously, there are significant side effects from radiation in regards to the valves, the coronary arteries, and that could happen in the future, but at least during the brief follow-up period, they didn't appreciate anything. And again, these were for very high-risk patients without another option. So take-home points, TBCs. Outflow tract TBCs are generally benign, but you should consider intervention when the patient is symptomatic or the EF is reduced, and that burden is generally around 10 to 20%. Idiopathic VT, so VT in the structurally normal heart, generally has an excellent prognosis. They generally don't need an ICD, and they can respond well to medications or catheter ablation. And then VT in the structural heart. ICD, again, is the standard of care, but catheter ablation has the ability to minimize ICD therapy, and in some cases, patients minimize antiarrhythmic use or to get away from amiodarone. Catheter ablation in ischemic cardiomyopathy generally has a better outcome due to the endocardial scar, but the risk is non-trivial, and the patients must be properly selected. I think that's that. Any questions?
Questions?
That's a really nice presentation. Based on what you've shown this morning, would it be worthwhile to develop a protocol for ablation in VT storm? Because currently that's a difficult thing to engage, especially on the evenings and weekends, and it's not something that's done a lot, I don't think.
I think it's very reasonable, and again, I think it depends. I think it's very reasonable to have some kind of protocol in terms of addressing the patient's risks and benefits. We can't always take every patient, and sometimes the risk outweighs that, but I think it's a very reasonable thing to think about immediately in regards to a possible treatment plan. So I think anyone comes in with VT storm, I think we should at least consider whether they're a candidate, and they may not be, but I think it's reasonable to consider it instead of just thinking about an increase in amiodarone as the only treatment option.
And I'm just going to make a comment. Actually, we rarely want to take someone to the ablation on a weekend initially for a VT storm. Usually, now we would do that, absolutely. We have always a lab on call in case we need to. But as you saw from the presentation, our priority always is to start with antiarrhythmic medication. These patients might require hemodynamic support, mechanical support during these procedures. They're not ideally done on a weekend with limited resources. And almost always there are multiple steps that we would do, including intubating the patients, putting them on amiodarone, doing many other things before we have to take them to the to an ablation procedure. Not that we wouldn't if that's the only thing available, and I think we would, but that's probably not always ideal.
This might be going off Dr. Mooney's question. When somebody comes in with known coronary disease, prior infarct, LVEF, and monomorphic VT arrest, a lot of times we'll activate the cath lab, bring them in when it's monomorphic VT. Is that the right thing to do?
I think it's yes. Yes and no. I think many times monomorphic VT is not due to acute ischemia, but I think initially I think it's the right thing to do. But it's low-hanging fruit. But most of the time it's not due to that.
Just another comment on the VT storm question. It's an excellent one, and it puts us all in a difficult situation when it happens. The success rate in the lab, though, is limited when these patients come in such a state. They have hemodynamic embarrassment, and we can't get a good map and successful ablation in those situations. So they usually take some steps to get them stable enough to undergo a successful ablation. Otherwise, they come out and they're in shock, and we haven't really changed the substrate much. So it is a challenge, and I agree with Dr. Abdehadi. Typically, paralyzing and intubating a patient can be a nice stabilizing step, and then antiarrhythmic drugs to get them to a place where we can have a successful and safe approach.
And it depends a lot on the substrate as well, because if you have acute injury, acute inflammation, then clearly the risk is going to be higher. And but if you have a stable substrate, I mean, the fact that Mike is asking the question actually represents the fact that catheter ablation has come quite a ways in terms of its safety and efficacy. So eventually, with the right resources, this could definitely be an option for a select group of patients. And so definitely we're looking out for that.
One other modality I was curious if you know any data on that I've seen anecdotally a couple times is thoracic sympathectomy. For people that, you know, we've been desperate, as you can imagine. I end up seeing a fair number of these patients too. And we're always trying to look for ways to fix this absent replacing their heart. So do you know much data on that?
There are some centers who are doing it, at least in retrospective studies. The recurrence rates for freedom from VT at 1 year are around the 50% mark, if I remember correctly. So it's a reasonable modality. It seems like the people who have bilateral intervention do better than just left-sided intervention. So I don't know much in terms of the patient selection criteria and what's considered high risk, but there are centers who are doing it.
That was a very nice talk. Thank you very much. In the MRI lab, we see a lot of subepicardial to mid-myocardial scar. And how do you approach that as far as in those patients? Do you lean for antiarrhythmics first if their burden is, let's say, greater than 10%? And how do you kind of put that in the overall scheme?
I'm curious as to what some of the other people think. I don't weigh the amount of burden so much rather than the location of the scar. I think it can be helpful when they have a high degree of epicardial or mid-myocardial scar, which may be a little more difficult to ablate. But I think the risk benefits of antiarrhythmics versus catheter ablation are kind of the bigger risk-benefit profile for me, rather than the amount of scar, per se.
If their monomorphic PVC is outflow, is it fair to say that's likely PVC induced versus if they're monomorphic PVCs or in their superior axis?
I think you can't make a diagnosis until you have PVC suppression and see how the EF responds. We've all seen outflow-related PVC cardiomyopathies, so it does happen even if it is the typical benign outflow. But I think it's very reasonable to first try PVC suppression, even a short-term total or amio, and see if their EF improves and see if that's the cause. But I think it can happen no matter the location of the PVCs, where it looks outflow or superior axis.
Just a technical question. When you made it nice and simple for us with the entry, exit, and the isthmus, and then I see you guys spending, hours in the lab with these points and dots everywhere. So why not like one line through the whole like VT area? Is that not possible? I mean, it looks like when you do a line, it should be interrupted.
I think we should do that. Jay, you were talking about how some people are starting to isolate these areas of scar, right? I mean,
people address the scar in different ways. The pen group is actually literally doing lesions around the point where they try to do an exit block, meaning that they paste within the scar, kind of like how we do PVI for AFib, but they paste from within the scar and prove that electricity doesn't get out of the scar. But your question is valid. I mean, people make the maps look all different ways, but the real goal is to try to get as much of that, the isthmus sites and the true critical VT circuits in that as possible. And so sometimes we might localize to a site of the scar based on where that VT is exiting. But in general, the more you get of that, the more potential long-term benefit you have, because other areas may be arrhythmogenic in the future, but it can't always predict that. So you want to get the clinical VT substrate, but you also get as much of that scar as possible for long-term success.
And I honestly think we have a very practical program here for VT ablation. You can go to other programs where they look for the clinical VT and they'll spend 4 or 5 hours inducing and mapping. And by the time they're ready to ablate, because they really figured it out, the patient is unstable and they don't do ablation. We've seen it over and over from very reputable, and they come here because of a failed ablation. We, as Jay mentioned, we do try to be very efficient in our procedure. We try to identify the scar, and we often do more substrate modification, just like you suggested, more than necessarily trying to find the exit and the entrance, because what's an isthmus today might be different. There could be a different isthmus tomorrow. Creating a line. Remember, unlike your stent that's whatever 5 meter long, each lesion is 4 millimeter, and you have to create a line to touch lesion and move the catheter very carefully, very gently, and spend 30 seconds to 60 seconds on each lesion, which is 4 millimeter. So creating that line takes a lot of time, even if you're extremely accurate and you're very skillful in moving the catheter. But I think here we often do ischemic VT ablation in 1 to 2 hours, sometimes 2 to 3 hours maximum, where I know in other, and we have excellent outcome. I know this is very subjective, but I know it. I see these patients every day. You're right. You could be more practical than trying to spend so much time identifying things that are only seen in books.
Any last comments?
No, thank you.
Okay. Thank you all very much. Please stop by on your way out and thank both Bristol Myers Squibb and Janssen for supporting our grand rounds this morning. Have a great week.